In this week's podcast, I sit down with Dr. Sophia Fornbacher, who is a good friend of mine. She's out in Riverside. She's fellowship trained emergency medicine physician, doing amazing stuff. We actually just taught a course together in Salt Lake City at the ACEP Scientific Assembly. Had a great time. We always do. Now, what we're going to talk about is something that, I'll be honest, I struggle a little bit with the nomenclature, but it's an artifact that I have seen countless times. I've kind of always known it was there, and I'm so thankful that somebody actually put it out there as a thing to be careful of, and that is the lip liner sign. It is a false positive when we're looking at free fluid in the setting of a fast examination. And there's some nuances there, and I'm excited to share them with you all to increase our accuracy. Check it out. Hello, my name is Jailyn Avila of the Ultrasound podcast, and we have a special guest who I'm hoping is going to become a regular on the podcast, Sophia Fornbacher. Sophia, how are you?
I'm doing great. How are you doing?
I am doing amazing. We've already recorded 2 podcasts separately. We've already published one. We have another one that talks about your experience going through medicine because you're relatively fresh out of training. You're in your 2nd year after residency, 1st year after fellowship. And that is 10 years ago for me. And so I have thoughts from my perspective. Oh, and also I didn't go through my medical training in the same space that you and I are both in now. So it was really nice to hear perspectives on that. And we're going to publish that hopefully shortly in the future. But what we're going to talk about today is something that was published in 2024. It's a sign that I have always noticed, and I didn't really have a name, and I was always just like, this is an artifact. And it's called the lip liner sign, which I have some thoughts on the nomenclature, and it's no shade to the authors. I'm so happy that they published it, and everybody's talking about it, so it's important. And it's a artifact that might give you a false positive for a fast examination. And the fast exam in general, I want to just touch briefly on it. I want to say that I now we have residents, we're like a hybrid community academic program where I work. We're a level 2 trauma. We have an affiliated level 1 trauma kind of down the road. And so all the big traumas go there. But I'm at a level 2 trauma. So we're seeing a lot of low speed MVCs. We're seeing a lot of fractures, but not a lot of needs to go to the OR from that trauma where I work. And I teach a lot of community docs at my shop and outside my shop. And I don't know, the fast exam, people ask about it all the time, but it doesn't seem to be that applicable to my shop and some of the places where I teach. And so I don't know, I just I don't focus that much on the fast exam. I feel like peripheral IVs, soft tissue ultrasound, and then echoes are probably the ones that are more important in the community practice. But I wanted to ask you, what are your thoughts on teaching the fast exam, and what are your thoughts of the fast exam in your clinical practice?
I've worked at both a kind of hybrid community academic shop and then also at a county academic shop. Both were level 1 traumas, and I honestly love it. I think the fast is great. Educationally, I think it's a great place to start teaching ultrasound. You're using a curvilineal probe. The images you're looking for are relatively straightforward, and it gives you a basic sense of anatomy. A lot of my level 2 traumas that we do fasts on at these sites, I agree, typically the fast is negative. But when you're getting those scary traumas at a level 1 center, I think it can definitely change your clinical management. And some of the things that I really enjoy about it is that it is an exam that's repeatable. So you can get kind of a scary trauma that's relatively stable, but if anything changes, the first thing you go to is doing your fast exam to see if there's now a new finding.
Oh, okay. So thank you for educating me. And that's the thing is that it's good. You should have your own perspectives on things. And that's part of why we have these podcasts is to discuss ideas and to figure things out. And actually really like that. So you're saying that you 100% vehemently disagree with what I'm saying.
Absolutely. Fast is the best thing ever.
That's fair. You know what? That is reasonable, and I accept that. I'm going to interrupt this interview just for a second to discuss the courses at the courses.coreultrasound.com website. We have a question bank with 3,200 questions with video reviews of the questions themselves to walk you through exactly why a question was correct or it was incorrect. And we have a brand new EM fundamentals course that was built essentially from scratch this past year, 100% new content. We have our primary care fundamentals. We have sonoanatomy. We have critical care course. We have a content creation course. We have everything that you might need on there. Check it out at courses.coreultrasound.com. Now, back to your video. All right. So you use it, and in your clinical practice, how often are you getting these, we'll say false positive in general, and how often are you seeing this lip liner sign in your clinical practice?
So to be honest, I feel like I've noticed it more now that I've been made aware of it after learning about this study. I've actually seen it a little bit more in my non-trauma patients where I'll see kind of the lip liner sign and I'm like, that doesn't track. This patient's not here for trauma. They don't have ascites. In my traumas, I'd say like if I gave it like a rough estimate, very rough, like maybe 1 in 10-ish, I feel like I'm seeing it. And then I pause for a second and look at like the clinical picture, like, okay, is the patient stable? What was the mechanism of injury? Like, how much do I believe this sign that I'm seeing?
Okay. Yeah, that's fair. And I mean, I think if you have that subtle of a positive fast, the patient, I feel like probably is stable, right? Because if it's just like this little rim of fluid, it's probably a small amount. You know, I'm thinking between 300 and 400 cc's, which is a lot, but that's still somebody that would be in stage 1 of shock if you believe those criteria, like the stage 1 through stage 4 of shock, as far as how much they've lost. And so likely the patient can go to the CT scanner, which is great. Usually when I have a hemodynamically unstable patient from blunt abdominal trauma and, you know, they're hemodynamically unstable from that internal blood loss, usually it's not subtle. It's like obvious that you can see it there. I've actually always seen this, like I mentioned, and I kind of like in my brain through all the years, I've just known that that's an artifact and not real, and I've not really known why. But we have something now where it's in the literature and a lot more people are now aware of it, which I think is good, even if, again, I'm not like a huge fan of the nomenclature. But I don't know, marketability, it might be good. I don't know. Can I run through some slides with you? Is that cool?
Yeah, let's do it.
So this is the study that I'm referring to. This is called the lip liner sign, and it is a case report, really a case series. It was published in 2024 in the Journal of Emergency Medicine. Shout out to all of the people that were involved. All right, so in case you don't know, this is a lip liner. It's supposed to be a little bit darker of a border around the lips to kind of emphasize, you know, I know our femmes might know exactly what this is, but our masks might not. And it's nice. I use lip liner every once in a while. I'm usually not this dark unless I'm doing it for a specific effect. Wait, do you use a lip liner?
You know, I've gotten into it recently just because I feel like it adds a nice crisp border, but I also don't typically have as much of a contrast. Again, unless it's something like more specific.
That's fair. And I honestly, I'm just touching on this briefly, but this, like the art of makeup is amazing. I've been enjoying it so much. We'll talk offline later about like feathering and, overdrawing your lips and all that stuff.
Oh my God.
This is the lip liner sign. And we're seeing here, this is a right upper quadrant view. This is the typical Morson's pouch view. This is where sometimes people say this is the only place you look, but we really need to look over here. Inferior pole of the kidney, which is here. Caudal tip of the liver interface. This is actually where fluid accumulates first most of the time. Little renal cyst here, probably a Bosniak 1. Doesn't really need follow-up. But if we go a little bit further, we can see around the border here of the liver, it's a little darker, which when we see something hypoechoic where we don't expect it, we for sure should think about a subtle fast. And I have seen subtle fast where it's just a very thin line and it be positive. Now, this case series here, it includes 4 different cases with a bunch of different machines. And I have noticed it more, at least in the past, with the sonocytes using the curvilinear transducer. But this is something that apparently is present in a lot of different machines. And kind of on retrospect, I have noticed that it is present on really all the machines. It might be a little more subtle depending on what preset you're using with your machine, but I have seen it on multiple ones. Now, this kind of makes me think of another false positive sign, which is just basically a prominent fat pad, which we can see right here. And sometimes when you are seeing this fat pad around the kidneys, typically it's a little more hyperechoic, a little more mixed density. But this actually has a sign that was described a while ago, actually. This is called the double line sign. It was first described in 2011. So we have Glisson's capsule up here, which is the capsule of the liver. And then we have Gerota's fascia, which is that border around the kidney. And it's basically showing these two lines and it being called something, being called the double line sign. There is the article, if you happen to want to look at it, and a shout out to Paul, shout out to Jason. They're both amazing ultrasound people. Also shout out to Mike. I just know Jason and Paul a little bit better. Here is an image showing both. So here we're seeing the double line sign here. So here's the Glisson's capsule, here's Gerota's fascia, here's the fat pad. And then on this same image, I actually got this the other day. If we scroll through, we're also seeing a lip liner sign. I'll go back a little bit. You see how it's just a touch darker right here? That is the lip liner sign. And if you want a little more kind of clarification, there they are. Do you want me to, should I zoom in? Let's zoom in a little bit. All right, so that's the lip liner sign, and this is the double line sign. Both are things that we can see that are relatively physiologic because, if someone has a very prominent renal fat pad, doesn't mean the patient doesn't have stuff. It just means it's not free fluid. And so those are the two signs, lip liner sign and that double line sign. Now, a little bit on the nomenclature, and this is like, listen, this is like no shade, right? This is like, it's got to be marketable, right? We were talking about this. But like a lip liner goes around the entire border of something. And I'm sure that there are looks where you just have lip liner on the upper or maybe the lower lip. But I don't know. I just like cognitively, I struggle with it. And so this sign, I made it up. It's supposed to say like it is equivalent to, it might be, or it might not. Do you like how I made up that little symbol?
I do. It's a very unique symbol.
Thank you.
And I think it portrays the message you're trying to send.
Thank you. You're so sweet. Now, I do have to say, like, I don't know, I think about the marketability of this, and I think about other things that I'm like, I kind of like understand why they're called that, but I don't agree with them. For instance, just going back, like back, I don't know, like when I was a resident and POCUS was becoming a word, POCUS for point of care ultrasound, I didn't like it because it was like, I don't know, it was just whimsical and magical. And I refused to say POCUS. I would just say bedside ultrasound for like a decade. But like, it was just me. And I just felt like, even though I don't like love it, like everybody knows POCUS now as a word. So I just use it. And I also think about that for lung ultrasound, for the subpleural consolidations, which are meant to be like small consolidations that normally they're 0.5 centimeters in diameter, all the way up to 3 centimeters in diameter. And my problem with subpleural consolidations is that it is like everything on lung ultrasound is subpleural. Every pathology that we see is underneath the pleura, right? There's not a whole lot of pathology that are, I don't know, like independent of the pleura, I guess. Right. And so for probably 5 years, I called it a small pleural consolidation. And I thought that was good because it's describing it a little bit better. But again, nobody calls it small pleural consolidation except for me. I didn't want to be an outlier. So now I just call it subpleural consolidation like everybody else, even though I don't agree with it. So like listen, I think lip liner is great, honestly. Yeah. I don't know. I wish it was a better one. I was thinking like outline sign, maybe like the organ border sign or like a pseudo capsule sign. But I don't know. What do you think? Should we try to push and call it something else? Or do you think lip liner is totally okay?
I think it's going to be tough because I do think like marketability is kind of a big thing, like whether we like it or not, but it's making something catchy, right? And I feel like every few years our attention spans get shorter and shorter, especially like that's true. In the emergency department.
Yeah.
I like the lip liner, but I do see that you are a rebel with a cause and we want like the name to make sense with the sign.
I do.
I kind of like like false capsule is, I think, but it's still like, honestly, like it's not as catchy. Not going to lie to you. Lip liner
It's
is very
really not.
catchy.
It's really not. Oh, I thought of one more. You know how when you are doing an ultrasound guided IV and then you have your probe in the long axis,
Yeah.
the short axis relative to the vein, and then your needles, also in short axis naturally, and then you have to like,
Yeah.
you bring it in and then you move it like that.
Mm-hmm.
So that has been described as like, I don't know, like leapfrog or walking the dog or something like that,
Oh,
leading
I've
the
heard
needle.
walking the dog.
How do you describe it? Do you have like a word that describes it?
I've heard walking the dog. There was also something about like a lantern or something because like the tip of the needle's like in the center, like I don't know, some kind of shining light thing, right? Because like when you're doing it, you want to keep that needle tip like in the center of your vessel, so it's like a little star
Okay.
in the dark night. But
All
that
right.
might just be out
Right
of my
on.
head.
Yeah, that's honestly, that's reasonable. So what I call it is I actually call it the sequential needle tip tracking. And I still to this day am calling it that
So
because
logical.
it says exactly what you're doing. Because I worry that if you say like leading the needle or walking the dog, that it doesn't fully grasp that you're moving one then the other, one then the other. When I hear those
Yeah.
terms in isolation, except for leapfrog, I guess leapfrog is good, except leapfrog makes me think you're lifting the transducer every single time, like you're leaping.
Right.
And so that's why I don't like that one. And it's a mouthful. It's not marketable, sequential needle tip tracking. But to this day, I refuse to call it anything other than that. But it's not very marketable. So I don't know. All that to say, should we just say lip liner, not fight it? Sophia, what do you think?
I think unless we come with something really good, it's going to be hard to fight. So we'll probably have to brainstorm about this offline.
We'll brainstorm. And in the meantime, anybody watching, listening, if you have any ideas, please send them our way. I don't know. Maybe we'll publish our own paper
I'm down.
and include
Let's
those
do it.
authors. Yeah, because
Absolutely.
we can do more than 4 patients, right? Like we can do more than 4 patients. All right. Well, any final thoughts? If not, I think that is a perfect summary of the lip liner sign. And it was about time, because it was last year that was published. It was about time that we talked about it on the podcast.
I think we covered all the bases. Just remember, fast is great. You ever have a hypotension patient? Don't forget to scan them.
I love that. Fast is great. If you have a hypotensive patient, don't forget to scan them. I love that. All right, that's all for today. Sophia, thanks again for taking time out of your busy schedule and chatting me through this whole thing.
Oh my gosh, anytime.
I hope you enjoyed that interview as much as I did. Remember, the lip liner sign is something that can happen that might cause you to have a false positive result with your fast examination in the peritoneal area. Shout out to the authors. Y'all did a great job. Thank you, Sophia, for being here and walking through this with me. I hope to hear from you soon, and happy scanning.